Thank you so much, Rudolph, for that great introduction, and thank you to Robert and Louisette and everyone who was involved in organizing this. It is an honor to be here. I mean, it's fun to speak at any event, but to come to somewhere outside my own country, this is really an honor and a thrill, and especially to be among such esteemed companies. So thank you so much. All right, and thank you, Dr. Ivo, because for setting the stage and talking so much about insulin. But Dr. Mesquite brought up a good point about the shortcomings of insulin, and hopefully I might address both of those in this talk. So let's talk about ketogenic therapies for neurological and neurodegenerative disorders. I don't know if I have to disclose conflicts, but if I do, I receive royalties from books related to low-carb and ketogenic diets, but I think if I didn't, I probably wouldn't be here. So I don't know why they consider that a conflict. Okay. Why do we need to look at new types of therapy for these disorders, neurological and neurodegenerative disorders? Why don't we just stick with what we do now? The problem is what we do now is this. The standard of care for these conditions is take your drugs and say your prayers. Is this really the best that we can offer? Is this really the best modern medical technology has to give people afflicted with these conditions? There's got to be something better out there. So why would we look at alternative therapies, and then why ketogenic interventions specifically? Well, I think we can all agree, I know there's a lot of medical professionals in the audience today, the conventional treatments are lackluster, and that is putting it kindly. The treatments are largely ineffective, and there are treatment-resistant cases, even in conditions and for which there are drugs and surgeries. There are certain people who don't respond as well to the interventions and therapies. And there's a decline in efficacy. So even again, where there's medicines that are effective, over time the efficacy wanes and you don't get the same effect from those drugs anymore. What about the side effects of the medications? Some drugs for Parkinson's disease, because of the way they interact with the dopamine system, side effects of some of these drugs can include increased risk-seeking behavior, like compulsive shopping, compulsive gambling. So great, okay, your tremor is gone, but you just lost your life savings at the roulette wheel. Is that really the best we can offer? Is that the best, again, that modern medical technology has to give these people? So why ketogenic therapies? So we would want any kind of alternative effective treatment. Why ketogenic interventions specifically? These are going to address commonalities in cellular energy. You're going to hear that word over and over throughout my talk, energy. And keto is one intervention that can address multiple things with one change, and you'll see that. So I beat myself to my own bullet point. Okay, the ketogenic diet, ketogenic therapies in general, are not new. This is not something that just was discovered yesterday. Look at what a difference a few decades can make. I don't know if that first cover made news in the Netherlands, but this is a very, very iconic image in the US, this frowny face with the bacon and eggs. Now, it's not just 30 years in the making, it's at least 50 years in the making. The ketogenic diet is no longer just a weight loss diet that your neighbor down the street lost 20 kilos, they did the Atkins diet, and we adore Dr. Atkins. His work has been completely vindicated, but look, the difference 50 years now. On the right, that is a textbook, and it's actually in its second edition. This is a textbook outlining all kinds of applications for ketogenic therapies. And has anyone here ever heard of Eric Westman? Anyone happen to know that name? Okay. Dr. Westman, I think you have a chapter in that book, right? Yeah, so I guess they have pretty low standards for who they'll let run. No, I'm just kidding. And it's becoming more even the mainstream. So you young doctors, you young medical students, it's no longer true that this is not a mainstream thing, that this is not endorsed by conventional organizations. The American Diabetes Association consensus panel came right out and said that reducing carbohydrate intake has demonstrated the most evidence for improving glycemia, blood sugar. Not just some, not a little, the most evidence. And I will go out of my way to recognize Dr. Westman's colleague, Will Yancey from Duke University. He's one of the authors on this consensus panel, and it's my understanding that if he had not been on that panel, this would not have turned out the way it did. He really stood up for the low-carbon ketogenic diet. 30 years, 50 years, keto goes back further than that. This is an ancient therapy. They knew since ancient times that there was something about fasting seemed to help people with seizures. It either made the seizures go away completely or they became much less severe and less frequent. But then they discovered around the 1920s that carbohydrate restriction could perform almost the same effects. You get almost the same effects of fasting while you get to eat food. Because it doesn't really matter how effective fasting is, eventually you have to eat. Can I eat something that's not going to trigger a seizure? Yes, don't eat carbohydrate. So there's something unique about not eating carbs that does something to the central nervous system, right? Now we have substantiated research on ketogenic diets for everything you see here. And when I say substantiated, I mean it's really undeniable. The amount of published scientific research on this is really not disputable anymore. So for everything here, and this, I call this emerging evidence because for everything you see here, there is published research. This isn't just made up. It's not all just anecdotes and stories. There is published research. It's just not as robust as the conditions on the other slide. Let's see. So I know that in the keto world and ancestral health in general, well, with keto specifically, you start to sound like a crazy person because for every condition someone's afflicted with, you want them to try keto, right? Oh, you have migraines. Have you tried keto? Oh, you have acid reflux. Have you heard of the keto diet? For everything someone has, you keto. And I don't know if this is a well-known saying in the Netherlands, but in the US, there's a saying, when all you have is a hammer, everything looks like a nail, right? Your tool, everything looks like it needs that tool. So we kind of, you really start to sound like a kook telling people, oh, keto. Well, somebody once said, keto is a really big hammer, and there are a lot of little nails out there. I wish I could take credit for saying that. I'm not that brilliant, but Jeff Volek is. And I'm sure many of you know that name as well. Okay, so what are we going to do about it? Let's dive into the neurological and neurodegenerative disorders now that we've kind of established keto is a real thing. It's a real medical therapy. It's not some crazy thing. These are energy problems. Remember I said we're going to hear the word energy a lot. And I'm going to read a bit, but it's worth it. Neurons are largely intolerant of inadequate energy supply, and thus the high energy demand of the brain predisposes it to a variety of diseases if energy supplies are disrupted. Neurodegenerative diseases are not classically thought to be caused by disturbed metabolism, but bioenergetic defects are emerging as important pathophysiological mechanisms in several disorders. Bioenergetic defects. Okay, I'm going to lay some groundwork by talking about Alzheimer's disease, and then we'll see how the same principles relate to some of these other neurodegenerative conditions. So they commonly refer to Alzheimer's disease as type 3 diabetes or diabetes of the brain. You will also sometimes come across the phrase brain insulin resistance. Where does this come from? It comes from the fact that depending on the source you cite, the human brain uses anywhere from 25 to 30% or 20 to 25% of all the body's glucose and oxygen. It is a very, very energy hungry organ. So if energy supplies are disrupted, might cognition be disrupted? And when I say that it's a metabolic problem, it has to do with the way the brain is getting and using energy. The predominant abnormality in late onset Alzheimer's disease is a 45% reduction in cerebral glucose metabolism. If your brain is using 45% less energy than a healthy person's brain, don't you think you might have some cognitive decline? Don't you think you might have some cognitive impairment? Oops. It's now widely acknowledged that brain hypometabolism accompanies Alzheimer's. Hypometabolism, Too little energy, not enough energy. A prominent and well-characterized feature of Alzheimer's is progressive region-specific declines in the cerebral metabolic rate of glucose. It's progressive, right? I always say nobody wakes up all of a sudden with very severe dementia. This is a progressive disease. It starts in a mild form that's called mild cognitive impairment, and it gets worse. And it's region-specific because at first, people afflicted with this condition can still take care of them. You know, they may become forgetful, they lose their keys. It's only as the disease becomes more severe and widespread that it affects more of the brain and more of those activities of daily life. So this is progressive, and it starts in regions before it spreads. Reductions in the cerebral metabolic rate of glucose are associated with increased Alzheimer's risk and can be observed years before dementia onset. This is critical. That's why it's in red. You know, red means important. I cannot emphasize this enough. This decline in the brain's uptake of glucose is measurable by PET scan in people as young as their 30s and 40s. Those people do not have any signs and symptoms because they are still young and healthy enough that the brain is compensating. So they don't have any signs of memory loss or impairment, but their brain is already starting to take up less glucose than a healthy person's brain. And it's only when this problem goes on so long that they start to develop the symptoms. And we're going to see that in some of the other conditions we'll talk about. And thank you so much to Ivo for talking about the importance of insulin and not just blood glucose. You're absolutely right. It is so glucose-centric, and we're really missing a huge part of this. So this is Dr. Kraft. This is an excellent book, especially for the medical professionals in the room. The book is about this thick. You could read it in a day. He really pioneered the use of the oral glucose tolerance test with insulin measurements. So not just testing blood sugar, but testing insulin at the same time and extending it from the traditional 2-hour test to 5 hours. And through doing that, he discovered that there were a lot of people with totally normal fasting glucose, totally normal hemoglobin A1C, but their insulin was very high. Whoops. So the pathology of diabetes occurs in those with normal blood sugar. Too many people are being told, oh, you're fine, your fasting blood sugar is fine. Normal weight, normal body mass index, normal fasting sugar, and even normal fasting insulin doesn't exclude type 2 diabetes, or Dr. Kraft thought hyperinsulinemia and type 2 diabetes should be the same thing. And this speaks to Dr. Mesquite's point, I think. Even sometimes the fasting insulin can be normal, but what happens after you eat a meal? And it skyrockets and it stays elevated most of the day. So you're right, fasting insulin can be very volatile. I still think it's really worth testing, but it doesn't tell the whole story. Just like fasting glucose, in many people that can be normal, but their A1C is elevated, right? Okay, so I love the phrase type 3 diabetes or diabetes of the brain because it immediately tells you there's something with glucose or insulin in this disease, right? But the problem with that phrase is that it's focusing on the glucose maybe and not so much the insulin. So chronically high insulin is the canary in the coal mine. This is our first earliest warning sign that something is wrong. So they did a longitudinal study, and they found that the risk of Alzheimer's doubled in almost 40% of the study population with hyperinsulinemia, was highest in people without diabetes. So this is Dr. Kraft's work in action. These people had normal blood glucose, but their insulin was high, and they had double the risk for Alzheimer's. Insulin resistance may be a marker of Alzheimer's risk associated with reduced cerebral metabolic rate of glucose and subtle cognitive impairments at the earliest stage of disease, even before the onset of mild cognitive impairment. Remember I said we can start measuring this in people decades before the disease manifests. I know you doctors and nurses out there, you see this with type 2 diabetes all the time. Nobody wakes up with diabetes. Your insulin is probably elevated for years. In some research says as much as 2 decades before the blood sugar starts to rise, when the insulin can no longer catch up. So your manifestation of type 2 diabetes, the high blood sugar, is the last thing to happen. It's the same thing here with the cognitive impairment. The first domino to fall is the chronically high insulin and the reduced brain glucose usage. And in my opinion, the memory loss and the cognitive decline and impairment are the symptoms. The disease is a metabolic disease. The disease is a fuel shortage. It's an energy crisis in the brain, the symptoms of which are memory loss and cognitive impairments. Okay, in case you think I'm just making this up out of thin air, because some of this might be new, you've all heard of metabolic syndrome. The connections now between metabolic syndrome and cognitive impairment are so strong that there is a phrase now, the metabolic cognitive syndrome. Metabolic cognitive syndrome. Is the insulin-resistant brain state a central feature of this metabolic cognitive syndrome? What about a metabolic approach for Alzheimer's? Anyone here familiar with the work of Thomas Seyfried on cancer? He talks about the metabolic approach to cancer. What about a metabolic approach for Alzheimer's disease? Okay, that's Alzheimer's, but I said this applies to a lot of other neurodegenerative conditions. So what are the commonalities between these conditions, and why would a ketogenic diet therefore potentially be helpful? Every one of these disorders, Alzheimer's, Parkinson's, multiple sclerosis, ALS, Huntington's, all of them have some degree of neuronal hypometabolism, and it is specific to glucose. These cells, for whatever reason, are not metabolizing glucose properly. There is, in every one of them, some kind of fuel shortage. There's mitochondrial dysfunction, or is it? I don't think the mitochondria are dysfunctioning. I think they are doing exactly what you would expect them to do under the conditions we present to them metabolically and diet and lifestyle. Most of these conditions have some degree of chronic hyperinsulinemia, neuronal atrophy and cellular malfunction, because if your neurons are not getting enough fuel, enough energy, of course they're going to atrophy, they're going to malfunction. In Alzheimer's disease, the shape of a neuron, you've got the cell body and an axon coming out, and the axon is supposed to send signals to the next neuron, right? And what happens in Alzheimer's, as these cells start to lose energy, the cells pull the axons and dendrites in. I say it's like a vacuum with a retractable cord. And so instead of the synapses and connections like this, you kind of have that. Those neurons are no longer communicating properly. So it's no wonder we have the kind of impairment that we see. Glutamate toxicity, eventually neuronal death. And I'll talk a little bit more about that. Some of these cells are not all dead. They're just hibernating. Again, why do we care? Why does any of this matter? Why is glucose, or energy in general, fuel, so important to the central nervous system? Whoops. Okay. There's no free lunch. Everything costs energy in the human body. So in order to even maintain that shape, maintaining the shape of those neurons and those axons and dendrites requires energy. No, it doesn't have to be glucose, but we need some kind of fuel. We need ATP. Nerve impulse transmission, to make that communication happen, also requires energy. We know that ketogenic diets are excellent for correcting electrolyte imbalances. It's one of the reasons it's believed to be so good for seizures, is that it corrects the polarity of the cell membrane. And so that also takes energy. All those sodium-potassium pumps require energy. The synthesis of neurotransmitters, everything costs energy. And there are certain compounds in the brain that have to come from glucose as a building block. So most of these we could just get ATP, we get energy from anything. Some of these things specifically do require glucose. Okay, let's talk about Parkinson's disease. The dopaminergic cell loss occurs in early Parkinson's disease, with more than 50% of the putamen dopaminergic terminals having been lost before clinical diagnosis. Didn't we see this in Alzheimer's? Isn't that reduced brain glucose metabolism is the first thing to happen? And you can lose a lot of function before you are even diagnosed, because that metabolic problem is brewing for a long time before it becomes severe enough that you have strong enough symptoms to even go to a doctor. Okay, what else do we see in Parkinson's that we saw in Alzheimer's? A high prevalence of undiagnosed insulin resistance in non-diabetic subjects. Again, non-diabetic because their glucose was normal, but they have high insulin. So this was, kind of a small study, only 154 people. 58% had undiagnosed insulin resistance with a normal fasting glucose. It's not a surprise that of the subjects that were overweight or obese, we see 61% or 83% with undiagnosed insulin resistance. Something that should make us take note, and Dr. Seidkins mentioned this, even those subjects at a normal weight, 41% of them had undiagnosed insulin resistance. This is not just a problem of larger people. You can have this metabolic problem at any weight. And the thing is, this was only based on the fasting insulin. So again, to Dr. Mesquite's point, there are a lot of people who will have a normal fasting insulin. How many more people might have been diagnosed if they tested it after a meal or after a glucose tolerance test? Is anyone here, have you heard that changes to your sense of smell or taste could be an early warning sign of Parkinson's? Sometimes they say Alzheimer's, so I see a few nods. Why? What does that have to do with Parkinson's disease? What could your sense of smell possibly have to do with any of this? Well, these are quotes from the studies. The citations are down there. Insulin transport varies among the brain regions. The brain is an insulin-requiring organ. The olfactory bulb, responsible for your sense of insulin protein, the highest concentration of insulin receptors. Insulin receptors are highly abundant in the neurons. Brain insulin receptors are highly enriched in the olfactory bulb. So maybe if there's some kind of problem with insulin signaling, we're going to have alterations to the sense of smell and taste. How interesting. What else? Now, there's a lot of words here, but I think they're worth reading. I might need my glasses for this one. There is growing evidence that a process analogous to peripheral insulin resistance occurs in the brains of Parkinson's disease patients, even those without diabetes. This raises the possibility that defective insulin signaling pathways may contribute to the development of the pathological features and suggests that the insulin signaling pathway may potentially be a novel target for disease modification. Given these growing links between Parkinson's disease and type 2 diabetes, it is perhaps not unsurprising that drugs used in the treatment of type 2 diabetes are among the most promising treatments currently being prioritized as novel treatments for Parkinson's disease. That was a lot of words, so I'm going to sum it up for you in like 4 or 5 words. Diabetes drugs for Parkinson's disease. Diabetes drugs for Parkinson's disease. If they didn't already know there was some connection there that was worth looking into, they wouldn't be looking into it. Research dollars are not easy to come by. Why would they be spending those precious dollars, those precious euros, on a treatment that was really not promising? They are using diabetes drugs for patients with Parkinson's disease. What about multiple sclerosis? So this pink is the myelin sheath, the myelin that insulates the neurons and helps neuronal communication happen better. And multiple sclerosis is conventionally believed to be an autoimmune attack on this myelin. And so you can see the myelin being degraded, and that is believed to be the cause of some of these things that we see. But there's other schools of thought. So we see in multiple sclerosis, just like in Alzheimer's and Parkinson's, I didn't talk much about the glucose, but patients with multiple sclerosis have lower fluorodeoxyglucose uptake in 40% of the brain compared to healthy controls. Decreased regional brain glucose correlates with the level of fatigue. Again, we see problems with energy. If these neurons are not taking up and using glucose properly, we're going to have problems. We also see hyperinsulinemia in a lot of these patients. Newly diagnosed MS patients, compared to healthy age-matched controls, when they did a glucose tolerance test, they had similar glucose results. The MS patients had higher insulin, lower insulin sensitivity. The degree of insulin resistance looks like it's tied to the severity of the disease in multiple sclerosis. This was, again, a small study, but this is emerging research. So before I forget, this is research in its infancy. I think it's extremely promising, especially considering the lackluster results of the conventional current treatments. But I think this is in its infancy, but definitely worth exploring and learning about. So it's a small study, but and they did, again, only fasting insulin. But even with fasting insulin, 14 subjects were already in territory we don't like. 33 of them, over half, had insulin resistance, but that is still based on the fasting insulin. How many more might have been diagnosed with insulin resistance if they did it postprandially after a meal? Okay, this is mice with experimental autoimmune encephalitis. That's the animal version of MS. You can lose as much as 15 to 30% of your spinal cord axons before permanent impairment. Again, you don't really have very, very severe disease until you've already lost a pretty substantial amount of functionality. Oops. The level, now, I said there's a different school of thought other than the autoimmune attack on the myelin. The level of disability correlates more strongly with axon destruction and degree of neuronal loss than with the demyelination. And what do we need to keep those axons the right shape and functioning properly? We need that energy. We need that ATP. So even when the myelin is starting to degrade, the neurons still function well if they can. Axons likely degenerate following demyelination only when they have inadequate energy. As long as they have enough fuel to do what they need to do, they can continue to do it. I don't want to run out of time, so I will, again, the oligodendrocytes are the cells that produce myelin. We have disturbed metabolism in the myelin-producing cells. And I said, are those mitochondria really malfunctioning, or are they actually doing something great? I don't know that these mitochondria are actually malfunctioning. I think if these cells are not taking up and using glucose properly, could that actually be a protective mechanism? Could these cells, I'm going to anthropomorphize, could these cells be saying, oh, I'm so damaged already from all these decades of hyperglycemia or hyperinsulinemia, I'm not even going to take any more glucose up. So I don't know if this is malfunction or dysfunction or actually a very elegant protective mechanism that when you look at the biochemical level. All right, ALS and Huntington's, we see the same thing. There is a little less research on these than on Alzheimer's and Parkinson's, but the same thing, dysregulation of energetic metabolism promotes the cell death. Neurodegenerative cells are the sites of metabolic and energetic abnormalities. Energy is the primary determinant of neuronal viability. This is all about the fuel. It is about the energy substrate that they can metabolize and get energy from. Okay, like I just said, the mechanisms through which the ketogenic diet remain unclear, but there is now compelling evidence that its efficacy is likely related to the normalization of aberrant energy metabolism. The concept that many neurological conditions are linked pathophysiologically to energy dysregulation could well provide a common research and experimental therapeutics platform from which the course of several neurological diseases could be favorably influenced by dietary means. That's a lot of words to say what I said much earlier. The ketogenic diet is one therapy. It's just a dietary change that could influence multiple different diseases. We already know it does because it influences what? Type 2 diabetes, hypertension, gout, non-alcoholic fatty liver, you name it. Now, even though this paper was co-authored by one of my favorite researchers in this area, Dr. Zhong Rou, and this might be the one thing I disagree with him about. There's the mechanisms through which the ketogenic diet works remain unclear. I think we can speculate quite a bit. Are we running out of time with all these? La la la, la la la. Oh, it's still going. Oh my gosh, look at all these mechanisms. Whoa. Oh, whoa. Yeah, it all fits on one slide, but like, these are only the ones we know about so far. What haven't we discovered? Now, if there was, from what you've learned so far, if there was nothing else on this slide except number one, that ketones, by way of producing ketones, the ketogenic diet can provide an alternative fuel to glucose. If that was the only thing here, that would be reason enough to try a ketogenic diet, wouldn't it? If the main problem in all of these conditions is that for whatever reason, the neurons are not taking up and metabolizing glucose, maybe there's some other fuel that we could give these cells? I wonder. Is there some other fuel source that maybe these neurons, And so look at number two. The story just keeps getting better because molecule for molecule, you get more ATP, you get more energy from fats and ketones than you do from glucose. To whatever extent chronically high blood sugar and or insulin might be causing or exacerbating, if not causing, these conditions, keto's great for fixing both of those too, right? We know that we call ketones and fatty acids like cleaner burning fuels than glucose, sort of less pollution, if you will, fewer reactive oxygen species. At least in animal studies, I'm not sure if they've shown it in humans. In animal studies, the ketogenic diet actually enhances mitochondrial biogenesis, making more mitochondria. If these diseases all have a factor of we're not getting enough energy, wouldn't it be nice if we could produce more energy factories? That's what the mitochondria do, right? They help us let's make more of those. And so many other things on here. And any one of these or all of these could potentially be helpful. I know Dr. Robert is where, I don't know where he is. He's there you are, very big on the microbiome. And so we don't know the changes in keto to the microbiome. More so in Parkinson's than with any of the other conditions. There's a lot of research about the crosstalk between the gut and the brain. And maybe the ketones themselves, like beta-hydroxybutyrate, one of the short-chain fats that are produced when your colonic bacteria ferment fiber is butyrate. And so maybe beta-hydroxybutyrate can have some of those same effects. We don't know, but this is all very promising. So this paper is also by Dr. Rowe. It's becoming widely accepted that the mechanistic underpinnings of the ketogenic diet are likely multiple, parallel, and possibly synergistic. So the question remains, can the ketogenic diet be packaged into a pill? At this state of knowledge, the likely answer is no. Why don't we think we can mimic the ketogenic diet with a pill? Because show me a pill that can do all that. Show me a surgery that can do all that. Show me any kind of therapy that can do all that. You know what does all that? The ketogenic diet. Now, there are pills and there are interventions that can do some of these, right? We have drugs for diabetes. Look at number 3. We have things that can address like 1 or 2 of these. Keto wholesale tackles all of these. So no, of course we can't have this in a pill. All right. Amy, wow, this is like you're blowing my mind. This is fascinating. Does it actually work? I bet it works great in mice. I bet it works great in fruit flies and in yeast cells. What about actual humans that have these conditions? So let's look at glucose and ketone uptake in the brain. The top line there, CTL, that's control. Those are healthy people, healthy cognitive function. The middle, MCI, that's mild cognitive impairment. And AD there at the bottom is Alzheimer's disease. And so the left is glucose uptake, and the right is acetoacetate, which is one of the ketones. Many of you are probably used to thinking of beta-hydroxybutyrate as like the brain ketone. The brain can also use acetoacetate. That's what they measured in this one. And acetoacetate, by the way, is the particular ketone that you measure if you test urine. Beta-hydroxybutyrate is the one from the blood. Either way, if you look at the top left, that is the control, the healthy brain taking up glucose. The more red, orange you see, the more of that is being taken up. So the healthy brain has no problem using glucose. There's no problem there. Mild cognitive impairment, there's a little bit less, but there's still quite a bit of red orange, so still getting some glucose. The Alzheimer's brain, there, the bottom left, there's almost no red orange at all, right? That brain is starving for fuel. That brain is starving for glucose. Glucose is knocking, nobody's home. Now look, do I have a, I think there's a pointer here, but that's it. Oh, yay. I wasn't really using it, but this. Look at the Alzheimer's brain on the acetoacid. Look at all that gorgeous red orange. Look at that brain sucking up ketones like a sponge. Does it matter? If we get ketones elevated in these people, does it actually enhance their cognition? You bet it does in most cases. Not only is the brain energy deficit in mild cognitive impairment specific to glucose, but at least partially correcting this deficit with ketones results in cognitive improvements. This is a study out of Sherbrooke University in Canada by a group, Dr. Stephen Cunnane. He's really phenomenal in this area. And I want to be clear, it's not a slam dunk. Not everybody has, improved cognition, but the fact that anybody does is a miracle. The fact that anybody with mild cognitive impairment or Alzheimer's, when I said that the neurons were not dead, they're kind of hibernating, I actually got that from Dr. Cunnane. If these neurons were dead, we would not see any improvement. If they're just offline, we're not going to see any improvement no matter what we do. But all of a sudden, you give these neurons a fuel they can use, and they come back to life, so to speak. It's almost like they were in power save mode, like in a low energy save mode. And then when you turn the power back on, they spring back into action. All right, let's look now. This is just one case study. It is a 68-year-old male who does carry that ApoE4 gene, which is the biggest genetic risk factor for Alzheimer's disease. And he has mild Alzheimer's disease. On the MoCA, that's the Montreal Cognitive Assessment Test, he's got a 23 out of 30, so that's mild Alzheimer's. And he has type 2 diabetes. He's been taking insulin for 15 years. Let's give him a ketogenic diet for 10 weeks. Let's do TRE is time-restricted eating, basically intermittent fasting, and moderate exercise. He goes from a mild Alzheimer's diagnosis to normal. He's back to a 29 out of 30 on the diagnostic test. His A1C decreases enough to the point that it would not be used to diagnose his reverse diabetes. The HOMA-IR is down significantly. The triglyceride to HDL ratio is down over 50%. Fasting glucose is down. Fasting insulin is down a ton. He loses a little bit of weight, but he's got all of these metabolic improvements, and the Alzheimer's is improved too. This is a younger guy. He's only 38. He also has that ApoE4 gene. He has metabolic syndrome, and he self-reported early memory problems. He wasn't officially diagnosed, but he took the test, and he did have a MoCA score of 22, which is cognitive impairment. Let's put him on a ketogenic diet for 10 weeks. He was already running a few times a week. He has a family history of Alzheimer's. Let's switch him to some higher intensity activity and lifting and a keto diet. And at least in this study, I like that they verified ketosis with a meter. So we know he was actually compliant enough to be in ketosis. And he had major improvements in just about everything. You can see there in the box a 58% decrease in HOMA-IR, 77% decrease in triglyceride to HDL ratio. His weight is down significantly. Fasting insulin is down over 50%. The most important thing is this on the left. He goes from a 22, he's got cognitive impairment, to a perfect 30 out of 30 after this ketogenic, a perfect score on this cognitive test. And so the thing that I want you to take away from this is that when you fix metabolic syndrome, you fix the metabolic cognitive syndrome. These are not unrelated, in my opinion. This is not a coincidence. This is not a coincidence that these researchers reversed his metabolic syndrome, and now his cognition is back to basically perfect. I don't think that's a coincidence. What about Parkinson's disease? Let's put people with Parkinson's on a ketogenic diet for 8 weeks. Well, actually, and let's compare a ketogenic diet to a low-fat diet. Let's see, ketosis, again, confirmed. We know they were in ketosis. They had their meter. And both groups improved comparably on the Unified Parkinson's Disease Rating Scale, except the ketogenic diet subjects improved more in the non-motor symptoms. The low-fat diet, look, 11% improvement in the low-fat diet, 41% improvement on the keto diet. So my friend Dr. Westman often says, for whatever condition, low-fat diets work, keto works better. Keto's just better. Low-fat worked for some of those people. Keto worked for more of them. And if you know anyone that has Parkinson's or if you're familiar with it, these non-motor symptoms can be more debilitating than the motor symptoms, right? Urinary incontinence, hallucinations, all these other things that can interfere with quality of life more than your motor impairments. Oh, I keep doing that. What else did I do here? I want to skip. Okay, thank you. What about metabolic syndrome? It's multiple sclerosis. We have too many abbreviations in keto. Let's see. Yeah, what about MS? And how many of you are familiar with Terry Wahls? The Wahls protocol? Yeah. I think she requires a lot that may not be necessary to get some of these improvements. She's got a lot of moving pieces that I think just shooting for strict ketosis might do away with the need for some of that stuff. But I mean, her research is certainly promising and she's able to reach a lot of people with it. Now, this is not her work. I just was wanting to point that out. Again, here we have a ketogenic diet for multiple sclerosis. And let's see, it's not so easy to see, but you can see the insulin comes down a few points. The A1C comes down just a little bit. Triglycerides are down substantially. HDL up a little bit. Ooh, wait a minute. Yikes. What about this pesky LDL? The LDL went up. Eek. Eek. Should we be worried about that? Should we be worried about the rise in LDL? LDL went up. Look what went down. The depression score and the fatigue score. Now, I'm not saying that higher LDL made them less fatigued or made them less depressed, but maybe the high LDL is not something to worry about when all those other things got better. So remember, this is all specific to glucose. One common feature in diseases characterized by neurodegeneration is disruption of the brain's energy metabolism. In all of these, in Alzheimer's, Parkinson's, ALS, and Huntington's, glucose hypometabolism in affected brain regions is prominent. Approaches which support brain energetics, such as ketone treatments, may slow disease progression or even delay or prevent onset if initiated early enough. Now, I'm running out of time. Let's see. Okay, I'm going to have to blow through this quickly. If we really want to get ketones, we want to give these starving neurons some kind of fuel, how are we going to do that? I think we could do it with a low-carb or ketogenic diet, but I know everyone in this room loves keto, we love low-carb, well, maybe there's some exceptions, but it's hard enough for someone who's young and healthy and really wants to do a ketogenic diet. It's hard enough sometimes for people to adhere long-term. Now try implementing this with someone who has motor impairments, cognitive impairments, behavioral disturbances. It's not easy. So are there other ways to get ketones? Yeah, there's fasting. You will produce some ketones if you fast, but fasting is not going to be appropriate for a lot of these people. They're elderly, they're already frail, they're already malnourished in some cases. I don't want those people fasting. So what about exercise? Even on a high-carb diet, if you exercise intensely enough, you will generate a little bit of ketones, especially if you're young and lean. You all probably know that coconut oil and MCT oil can raise ketone levels, even if you're not on a ketogenic diet. I read a blog post by a PhD in biochemistry once who said you could put coconut oil on your pasta and you'll be in ketosis, So that is a way to help generate those ketones, even if somebody is unable or unwilling to do an actual ketogenic diet. I have to talk about the exogenous ketones here because I don't think that those are a weight loss tool. They're not a diabetes reversal tool, but I think that they have a lot of promise in these type of neurodegenerative situations. Because if the main problem is that just these cells are starving, we need to give them some food. We need to give them some fuel. And we can do that with the exogenous ketones. And a lot of the research being done now, especially in Alzheimer's, is using those. And it's promising. But I need to point out that just giving the ketones, whether through MCT oil or the exogenous ketones, is not going to alter the fundamental disease process. You're going to, I'm out of time, give me 2 more minutes. You will generate, you will give those cells some fuel, which is great, but the underlying problem's going to keep getting worse. And I liken it to bailing water out of a leaky boat without stopping to patch the hole. You're managing the acute crisis, you haven't fixed the actual problem. So to whatever extent chronic hyperinsulinemia and hyperglycemia are causing or exacerbating these, we need something to correct that. And the exogenous ketones and MCT oil are not going to do that, but the keto diet will. I will just summarize this real quick. Is there a window of opportunity? Are you going to get to a point where it's too late, where you can't? Unfortunately, I do think some of these diseases are going to be so severe that no matter what you do, it won't help. Ketogenic diet, exogenous ketones, it won't help. So I think the sooner you can intervene, the better. The earlier this is identified. But I also think it's never too late. It never hurts to try, especially the exogenous ketones. Even if you can't alter the disease process, you're still going to get worse. If you can just improve that person's quality of life a little bit and their caregiver's quality of life a little bit in the time they have left, why wouldn't you do that? So I hope after all of this, your question is no longer why would somebody try keto for these? It's why would you not try keto for these neurodegenerative conditions? The standard treatments, the conventional interventions, the existing tools are not getting the job done. I think it's time for the big keto hammer that Dr. Volek mentioned. So thank you everybody for being here. Thank you.